Hi everyone. Today we are going to discuss about osteosarcoma. So I'll be covering only the important aspects, mostly which will be asked in the exams. So I'm not going into very details. So this will be serving the purpose, I think. So the first thing we need to understand is it is the most common primary malignant tumor. This is the first thing you need to understand. Then these are originating from the mesenchymal cells, which produces osteoid or immature bone. So this osteosarcoma is the most common primary malignant tumor in children and adults. So your questions will come like the most common primary malignant tumor in children and adolescents. This will be most commonly occurring in the around the second decade. So you should remember this. So then coming to the sexual preponderance. Here the males are most commonly affected than the females, but there is an exception to that. There is a type known as parosteal osteosarcoma. So this parosteal osteosarcoma is most common in females, and this distribution is bimodal. This can occur either in the primary, when the primary osteosarcoma can occur in 10 to 25 years, that is around the second decade, or secondary around 40 to 60 years, around the fifth decade. That is, the peak is for primary osteosarcoma second decade, and for the secondary osteosarcoma it is the fifth decade. So then coming to the location, so the most common location where this osteosarcoma arises is metaphyseal region, as you can see in this diagram. So it is always metaphyseal. So the most common sites is, the first site is your distal femur, followed by your proximal tibia, followed by your proximal humerus and your proximal femur. So the most common site is distal femur and proximal tibia. So coming to the etiology or the predisposing factors, or the pre-malignant or predisposing pre-malignant conditions which can cause osteosarcoma. So the first thing what you should remember is your previous radiation therapy. That is, radiation is a predisposing factor for osteosarcoma. Then you have your RB1 gene and your P53 gene mutation. That is, in your cases of retinoblastoma and your Leigh-Ferroni syndrome. So this is likely to be asked in your entrance examinations. So which is the predisposing factor, like retinoblastoma and Leigh-Ferroni syndrome can lead to osteosarcoma. And this Paget's disease is also very important, which will cause secondary osteosarcoma. Then you have your fibrous dysplasia and diaphyseal achalasia. So coming to the clinical features, the single most important clinical feature is your progressive pain, and this progressive pain is because of the bone infarction. And the other clinical features include your swelling, your shiny skin and your dilated veins. So all these are hints that can be seen in your questions. So coming to the radiology part, so these lesions can either be a blastic or a lytic lesion. It is not very particular whether it is blastic or lytic. So these can be both. This can be occurring as both blastic as well as lytic, and these have a ill-defined borders. So they are not very much defined. They are like ill-defined since it is a malignant tumor. So these also have periosteal reaction. This is very important. This periosteal reaction is very important. So this will give a clue in your exam on what question they are asking. So the first periosteal reaction what we are going to see is your Godman's triangle. So Godman's triangle is nothing but a triangular area of subperiosteal new bone formation. For example, in this what you are seeing, this is the cortex of the bone, and you can see an elevation here. So this elevation is nothing but your Godman's triangle. So it is a triangular area of subperiosteal new bone formation. So this area is your Godman's triangle. On the other hand, you are seeing something which is known as your sunburst appearance, which is nothing but, can you see the calcifications here? So this is the calcification of the Sharpie's fibers along the periosteum, so which will look like a sun ray appearance. So this is known as sunburst appearance. So the two important factors what you should see or what you should remember here is, one is your Codman's triangle, which is nothing but a triangular area of subperiosteal newborn formation, and the other one is your sunburst appearance, which is the calcification of your Sharpie's fibers. So these two can be asked directly or indirectly in your exam questions, which will hint out to the diagnosis that it is a case of osteosarcoma. So what are the other imaging modalities and what we are interested in? So the other thing is MRI. So why MRI is very helpful? First of all, to determine the soft tissue involvement, and then we need to find out whether there are any skip lesions. Can you see in this image, you can see the osteosarcoma is here, but you also see the skip lesion elsewhere. So this can be identified with your help of your MRI. And even if there are any skip lesions, they can also be diagnosed in your bone scan. Here there is nothing but whenever there is a skip lesion or whenever there is any bony metastasis, that can be diagnosed by your bony bone scan. So then the investigation of choice is biopsy. So then laboratory investigations. So in a tumor, why are we worried about this laboratory investigation? Here, this laboratory investigation, that is your serum ALP, is a very important factor in this osteosarcoma. So what does this serum ALP? So this serum ALP is usually elevated in cases of osteosarcoma. So why this is elevated? It is nothing but it reflects osteogenesis. So what is the importance of this? So whenever the serum ALP is elevated and you are suspecting a tumor, it is a blastic tumor. That is, it is reflecting osteogenesis. So the degree of elevation is based on your neoplastic activity. So whenever the patient is having increased ALP, that means the patient is having worse prognosis. So this can be asked in your question. So which is the worst prognostic factor? The other investigation what we do is your LDH. So LDH can also be increased in osteosarcoma, which is once again lead to your worst prognosis. So whenever you're seeing ALP and LDH is increased, that means the patient might have worse prognosis. So one more thing, what is the use of this ALP? So this ALP, whenever the patient is undergoing any treatment, and this ALP can be used to monitor the progress of the treatment. So what do you mean by that? That means whenever during this period of treatment you repeat an ALP, if it is decreased or it is in the decreasing trend, that means the patient is responding to the treatment. So in some cases it might be increased, which can indicate that the patient may have a recurrence or the patient is having any metastasis. So I hope you understood the importance of ALP. So the most common site of metastasis is your lungs. So your lungs are the most common site of metastasis in osteosarcoma. So coming to the histology part, you have to remember two important things. One is this region and this region, where you can see these are the osteoid matrix or osteoid production areas, the osteoid matrix. And then what you can see here is your atypical spindle cells. I'll read it again. These are atypical spindle cells with hyperchromatic nuclei. So these are diagnostic and characteristics of your osteosarcoma. So first thing is your osteoid production or osteoid matrix, and second thing is your spindle cells. So you should remember this osteoid and this spindle cells. So these are characteristic of your histopathological features of your osteosarcoma. So then coming to the treatment part. So we have given an introduction, we have given a radiology features, then we spoke about the epidemiology, we spoke about the histopathology, we spoke about the clinical features. Now we come into the treatment protocol. So how do we proceed? So first thing is your diagnosis. So this diagnosis can be made radiologically, or a biopsy proven diagnosis can be done. So once you have diagnosed the patient as osteosarcoma, so the next step is your neoadjuvant chemotherapy. So this is very important. So this neoadjuvant chemotherapy, the patient will undergo 3 to 4 cycles, and then followed by neoadjuvant chemotherapy, we will assess the response by Hughes grading. We will discuss further what is Hughes grading in the coming slides. So once you are satisfied and you think that the patient can undergo surgery, then the patient is subjected to surgery and reconstruction. So followed by post-op chemotherapy. So this is the treatment protocol, whereas first you are diagnosing the patient as osteosarcoma. After that, following that, the patient will undergo neoadjuvant chemotherapy, some 3 to 4 cycles. Then we'll assess the response, and then we'll proceed with surgery and reconstruction, and finally the patient will undergo post-op chemotherapy. So now next important thing is your chemotherapy. So in chemotherapy, what drugs we use? This is a very important question, and here we use something known as your MAP regimen. This is nothing but a mnemonic. So here, what does MAP? MAP is nothing but your M stands for your methotrexate. Here we give a high dose of methotrexate with adriamycin and platinum drugs, that is your cisplatin. So these are the 3 important chemotherapeutic drugs that are mainly used in treating your osteosarcoma. So these are the 3 important main drugs. There are also other drugs, but you remember these are the 3 important drugs that can be given for osteosarcoma. So once you give this chemotherapy, as we earlier discussed, there is something known as response. So what is the response? How to assess this response? That is why we have this Hughes grading. We will not go into the details, just know only one thing. In this Hughes grading, it is a histological based grading. Here, when the necrosis is more than 90%, then the response is good. This is the only thing I want you to remember. So the response can be even 100%, but if it is less than 90%, then the response is poor. If the response is more than 90%, the response is good. This is what I need you to remember. In some books it says even more than 85 is good response. It depends upon the question which we are going to attend. But remember, more than 90% or grade 3 and grade 4 are good response. So coming to the surgical aspects, here whether you want to do a limb salvage or you want to go with an amputation. But what we widely prefer is your surgical treatment with wide resection and reconstruction. So what does this word wide resection means? Wide resection is nothing but removing the entire tumor along with the circumferential cuff of a healthy normal surrounding tissue. So that is what is known as your wide resection. So reconstruction, what we use? We use endoprosthesis. So for reconstruction, we use endoprosthesis. Endoprosthesis is nothing but your artificial joint or something like that, which can decrease the morbidity of the patient. So amputation is also a treatment of choice. It used to be the gold standard treatment, but since now we are having advanced medical methods, surgical advances, so we are not doing amputation, and it is not commonly done nowadays. It can be. So now coming to the prognosis. So here the most important thing what we need to discuss is the poor prognostic factors. All these are poor prognostic factors where you need to remember by the mnemonic LAME. So L stands for your large tumor. A stands for your tumors affecting the axial skeleton. M stands for your whenever the patient is having metastasis at the time of diagnosis, it leads to a poor prognosis. And E is nothing but your elevated, as we already discussed, it is your elevated ALP and LDH. And one more poor prognostic factor is your poor response to chemotherapy. So this sums up your osteosarcoma and what you need to understand from osteosarcoma. I have just summarized everything in a single slide where you need to go through this. Only this is more than enough to attend your exams, which can easily fetch you marks in your osteosarcoma. So just we'll quickly go through what are these. Here, the first thing, your introduction. What you should remember. Introduction, you should remember only two things. One is it is the most common primary malignant tumor, and it is the most common primary malignant tumor in children and adolescents, most common in the second decade. So then coming to the etiology, it is more common in males than females. There are two types of osteosarcoma. One is your primary and secondary, whereas the primary is seen in 10 to 25 years, that is around the second decade, and your secondary osteosarcoma is around 40 to 60 years, which is seen in the fifth decade. So what are the predisposing or the pre-malignant lesions? So you have your Paget's disease, your fibrous dysplasia, and your previous radiation therapy, and genetically you have your retinoblastoma, that is your RB1 gene mutation, and P53 gene mutation, that is your Lee-Fraumeni syndrome. So coming to the location, it is metaphyseal in location, and the most common site is your distal femur, proximal tibia, and your proximal humerus. So coming to the clinical features, you have to remember that the progressive bone pain is the most important clinical feature, and the most common site for your metastasis is your lungs. So radiologically, the X-ray will show you either blastic or lytic lesions. Then you have your Codman's triangle and your sunburst appearance. In MRI or bone scan, this is used mainly for to identifying the skip lesions and your metastatic workup. So histopathologically, there is an osteoid matrix and an atypical spindle cells. So treatment. So first of all, you need to understand the pathway of treatment. So first you need to diagnose, then neoadjuvant chemotherapy, followed by a surgery and reconstruction, and fourth is your post-op chemo. So what are the chemotherapeutic agents used? It is your MAP regimen, that is your high-dose methotrexate, adriamycin, and cisplatin. So what is the surgical option here? You have your wide resection and reconstruction. So the last option is your amputation. So what are the poor prognostic factors? You remember the mnemonic LAME. So it is a large tumor. It is appendicular skeleton, axial skeleton. It is your axial skeleton. It is your metastasis at the time of diagnosis and elevated ALP and LDH levels. So I hope this video will be very useful. Thank you.